Welcome to the deep dive. Today we're getting into something really vital. Coronary artery disease, or CAD, and that classic symptom, chronic stable angina. We've gathered, the essential info on risks, how it's diagnosed, and what happens treatment-wise, stuff you really need to know. And it all starts with the heart itself, right? The myocardium. It's working incredibly hard all the time. Think about this. It uses about 75% of the oxygen it gets. That's huge compared to other muscles.
Exactly. There's just very little wiggle room.
So if demand goes up, maybe you're exercising, stressed out, and the supply lines are narrowed, problems happen fast.
Yeah, and that supply problem, CAD, it's fundamentally atherosclerosis. Plaque building up in those main coronary arteries branching off the aorta. It's usually a slow burn, a chronic thing. But interestingly, if it is slow enough, the body sometimes tries to adapt.
Adapt how?
It can actually build tiny new vessels, collateral circulation we call it, sort of like natural bypasses.
Wow, nature's workaround. But you definitely don't want to count on that.
No, absolutely not.
So let's talk prevention, the risks. We know some things you can't change, like getting older or family history, but where should people focus their energy? What's the action list?
Right. The non-modifiable ones are age. Being male, though, that gap closes post-menopause for women, family history. Even ethnicity plays a role. But the modifiable list, the things you can tackle, that's where the action is. We're talking high cholesterol, high blood pressure, diabetes management, really key. Quitting tobacco, getting more active, managing weight, and dealing with stress.
That's quite a list. And the lifestyle changes the sources mentioned sound, intense. Decreasing saturated fats, cholesterol, so less red meat, egg yolks, whole milk, more complex carbs, fiber, fruit, veggies. And the salt thing, less than 2 grams a day. That sounds really tough for most people.
It is tough, very tough if you're not already used to a cardiac diet. But the principle, right, lowering salt helps with blood pressure, and high blood pressure damages arteries, so it's about reduction. Same with alcohol, moderation is key. 1 drink a day for women, 2 for men, max. And exercise. Doesn't have to be heroic. 30 minutes, moderate activity, most days. Plus some weight training is good too.
Okay, so a lot of this connects back to cholesterol. Dyslipidemia. Let's dive into that. People hear cholesterol and think bad, but it's not quite that simple, is it? We actually need it.
We absolutely do. For cell walls, hormones, vitamin D, it's essential. But it's all about the balance and how it's transported. That's what the lipid panel tells us. You've got LDL, that's the bad cholesterol. Think of it like a delivery truck that sometimes spills its load plaque into the artery walls.
Do you want LDL low?
Exactly. Generally, under 130 milligrams per deciliter is a good target for many people. Then there's HDL. That's the good cholesterol. This is more like the cleanup crew. It carries excess cholesterol away from the arteries back to the liver to be processed. So you want HDL high.
Higher the better.
Pretty much. Over 45 for men, over 55 for women, ideally. And finally, triglycerides. They're basically stored fat from unused calories. If those get too high, say over 200, that adds significantly to the risk profile.
Right. And if lifestyle changes aren't enough to get those numbers in line, then medications come into play. Let's talk about the big ones, starting with statins. Things like atorvastatin, simvastatin, super common. How do they work, and what are the main watch-outs?
Okay, statins work mainly in the liver. They inhibit an enzyme involved in making cholesterol, so less cholesterol gets produced and your LDL levels drop. Pretty effective. The big cautions, though, are really important for people to know. First, liver function. We monitor liver enzymes because they can sometimes cause inflammation, hepatotoxicity.
Okay.
Second, and this one gets talked about a lot, is muscle issues, myopathy. In rare, severe cases, it can become rhabdomyolysis, which is serious muscle breakdown.
So someone's on a statin and gets unexplained muscle aches, especially in the legs.
They need to report that immediately. That's a key teaching point. Don't just ignore it.
Got it. What about niacin? I've heard it works well, but people struggle to take it.
Yeah, that's the main challenge with niacin. It's good at raising HDL, the good stuff, and lowering LDL. But the side effect, intense flushing, itching, especially in the face and upper body, it can be really uncomfortable.
Makes it hard to stick with.
Exactly. Taking an aspirin or ibuprofen about 30 minutes beforehand can sometimes help lessen that flushing, but it's still a barrier for many.
Okay, and then bile acid sequestrants, like cholestyramine.
Right. With those, the mechanism isn't the main takeaway for most people, it's the timing. They work in your gut, binding to bile acids so they get excreted instead of reabsorbed. This forces the liver to use up more cholesterol to make new bile acids. But because they bind things, they can bind other medications too and stop them from being absorbed properly.
So interference is the issue.
Big time. You absolutely have to time other medications carefully. Usually take other meds either an hour before or maybe 4 hours after the sequestrant. Otherwise, those other drugs might not work effectively.
Okay, that's crucial timing advice. Let's shift gears to the symptoms themselves. Chronic stable angina, CSA. This is when the heart's oxygen demand, maybe during activity, outstrips what the narrowed arteries can supply. But the key here, as you said, it's transient, reversible, no permanent damage, right?
That's the defining feature of stable angina. The heart muscle is briefly starved of oxygen ischemia, but it recovers. No cell death has occurred. And it's often very predictable. That's why we call it stable.
Predictable how?
It's usually triggered by things that make the heart work harder, physical exertion, yeah, but also emotional stress, exposure to cold, even digesting a big meal. The feeling is typically described as pressure, tightness, squeezing, maybe a dull ache, not always sharp pain.
And the duration?
Short, usually less than 15 minutes. And critically, it gets better with rest or with nitroglycerin medication.
But you mentioned earlier, not everyone gets that classic chest pain script.
No, definitely not. And this is so important. Patients with diabetes, for example, might have nerve damage neuropathy and experience silent angina, no pain at all. Others might present with what feels like indigestion or maybe just sudden shortness of breath, nausea, or really profound fatigue. They might not connect it to their heart initially.
Which makes diagnosis trickier.
Absolutely.
This leads us to a really critical point for listeners. Telling the difference between stable angina and a full-blown emergency, acute coronary syndrome, or ACS. So, recap. Stable angina, predictable pattern, short duration, under 15 mins, relieved by rest nitro, and crucially, normal troponin levels in the blood.
Correct. Now, contrast that with unstable angina. Here, the pattern changes. The pain might be new, or it's getting worse, happening with less effort, or even at rest. It lasts longer, maybe more than 15 or 20 minutes. But here's the key overlap. Troponin levels are still technically normal.
So, no cell death yet, but it's heading that way. It's unstable.
Exactly. It's a very high-risk situation, often a precursor to an actual heart attack, an MI.
And the MI, the myocardial infarction, that's the emergency. That's when cell death occurs. And the proof is in the blood work.
Yes. Troponin is the gold standard biomarker. It's a protein found inside heart muscle cells. It only gets released into the bloodstream when those cells are damaged or die.
So if troponin is elevated.
If we see troponin levels rising, usually starts about 2 to 6 hours after the injury that confirms myocardial damage. That's what separates MI from unstable angina.
Okay. So someone comes in with chest pain. Job one is rule out MI. You mentioned labs, troponin, maybe a lipid panel too. What else happens quickly?
A 12-lead EKG, or ECG, quick, non-invasive, gives us multiple electrical views of the heart, looking for signs of ischemia or dangerous rhythms.
And then maybe a stress test.
Often, yes. It's a way to see how the heart handles increased demand. We take images at rest, then during exercise, usually a treadmill. Or if someone can't exercise, we can use medication like dobutamine to chemically stress the heart. We're looking for blood flow problems that only show up under stress.
If those tests point towards significant blockages, what's the next step? The more invasive one?
That would be cardiac catheterization, also called an angiogram or PCI, percutaneous coronary intervention. It's invasive, yes, but it's both diagnostic and therapeutic.
How does that work?
We guide a thin tube, a catheter, through an artery usually in the wrist, radial, or groin, femoral, up into the coronary arteries. We inject contrast dye and take X-ray videos. This lets us see exactly where and how severe any blockages are.
And you can treat it right then and there.
Often, yes. If we find significant blockages, generally meaning more than 70% narrowed, we can perform an intervention. Usually involves inflating a small balloon at the blockage site, then deploying a stent, which is like a tiny mesh scaffold, to hold the artery open.
That's PCI.
That's PCI. Now, if the blockages are too numerous, too complex, or in difficult locations, stenting might not be the best option. In those cases, the patient might be referred for open heart surgery, coronary artery bypass grafting, or CABG.
Okay, let's talk practical application. After a cardiac cath, especially if they went through the femoral artery in the groin, what are the immediate nursing priorities? What do people need to watch for?
Post-cath care is crucial. Number one is monitoring the access site for bleeding or hematoma formation. We check distal pulses frequently, making sure blood flow to the leg or arm is good. Neurovascular checks too. And keeping that limb still is key. Strict bed rest, legs straight, usually for 4 to 6 hours if the femoral artery was used, to allow the puncture site to seal.
You mentioned hematoma. What's the big worry there? Something called a retroperitoneal hematoma.
Yeah, that's a serious, though less common complication with femoral access. It's bleeding behind the abdominal lining, so you don't necessarily see a big bruise on the surface right away.
So how would you know? What are the signs?
The patient might complain of back or flank pain. They might feel faint or nauseous. And the vital signs tell a story. Heart rate goes up, blood pressure starts dropping, maybe some abdominal tenderness. Recognizing that pattern quickly is vital.
Okay, critical post-procedure care. Now, let's wrap up with managing an acute angina attack. Someone feels that chest pain starting. What's the drill?
The immediate steps are standard protocol. Get the person sitting upright, makes breathing easier. Administer oxygen if available, check their vital signs, and then pain relief, which usually means nitroglycerin, NTG. Short-acting NTG is the first line for an acute episode.
And the teaching around using MTG is paramount, right? The 5-minute rule. Let's nail that down.
Absolutely. This is maybe the most important piece of patient education for someone with known stable angina. Step 1, sit down immediately. Don't keep moving. Step 2, take 1 dose of the short-acting NTG, usually a spray or a tablet under the tongue. Step 3, rest for 5 minutes. Step 4, if the symptoms are exactly the same or if they're worse after those 5 minutes, call 911 or emergency services immediately. Don't wait.
Call before taking more.
Yes, call 911 first. Then, if instructed or if still waiting, they can take a second dose. They can take up to 3 doses total, each 5 minutes apart. But that call to EMS after the first dose doesn't improve things is non-negotiable.
Got it. Call 911 if the first dose doesn't work in 5 minutes. What about just general safety with NTG?
Good point. It's sensitive stuff. It needs to be kept in its original dark glass container, tightly sealed. Heat and light break it down quickly, making it less effective.
So check the expiration date, store it properly.
Definitely. And the other huge safety warning, never, ever take NTG with erectile dysfunction medications, drugs like sildenafil, tadalafil.
I know.
The combination can cause a sudden, severe, potentially life-threatening drop in blood pressure, absolutely contraindicated.
Okay. And sometimes people use NTG before activity.
Yes, prophylactically. If they know a certain activity usually brings on angina, they can take a dose 5 or 10 minutes beforehand to help prevent it.
What about the long-acting forms? Patches, pills?
Those are for prevention, not acute attacks. They provide a steady level of the drug. But the body gets used to nitrates quickly, tolerance develops. So people using long-acting forms need a nitrate-free period each day, usually 10 to 14 hours, often overnight, to maintain the drug's effectiveness.
Right. So stepping back, the big picture here seems to be about control and knowledge. Modifying those risks we talked about earlier, managing other conditions like diabetes or high blood pressure, knowing the signs of trouble, and crucially, knowing exactly what to do, like with the NTG protocol.
That's exactly it. It's about understanding the whole spectrum, from managing cholesterol early on, knowing your LDL, your HDL, to recognizing the difference between that temporary discomfort of stable angina and the emergency signals of unstable angina, or an MI, confirmed by that troponin level, and then having that action plan for acute episodes. That knowledge really empowers people.
So let's leave you with a final thought. We mentioned at the start how the body can sometimes build those tiny collateral blood vessels if blockage develops really slowly. If your own system has that potential for resilience, what does that tell you about the impact of risk factors? Some might cause rapid plaque buildup, while others might contribute more slowly over time.
It's an interesting angle.
Yeah. So maybe consider what slow-growing risks might be creeping up in your own life. Is it chronic stress? A slow upward drift in weight? Maybe lipids that haven't been checked in a while? Think about what you could modify today to nudge your cardiovascular health onto that slower, potentially more resilient track.